Welcome to the Prescription Strength Podcast. I'm your host, Dr. Lynette Hewitt, GP and personal trainer, bringing you health and strength without the hype. Thanks for listening. Adam, thank you very much for giving me a bit of your time this afternoon.
Thank you very much for the invite, Lynette. Looking forward to the chat.
I wanted to talk to you as a fellow worker in the NHS who sees people in clinics, non-pre-selected clinics, I think is the thing that I often make reference to. But likewise, you've got a big presence online and so are well placed to be able to see firsthand how different these worlds are. And I would like to start perhaps by just getting your views on what physiotherapy is, but from the point of view of what you think people think they're getting when they come to see you versus what it actually is.
Yeah, great question. And there's two answers there, pretty much as you've outlined what people consider to be physiotherapy, culturally, societally, and then what I actually think it is or what it should be, which isn't as well known or well received, I think. So to start off with, what most people think physiotherapy is a subservient healthcare profession, a non-autonomous healthcare profession. Glorified masseuses, I think, is another common reference that we often get subscribed to, where when you have a back pain, a neck pain, a shoulder pain, you go and you get some massage, you get some treatments, which may involve some machines, some lasers, something that vibrates. And then you're given a poorly photocopied sheet of exercises to go and do some low intensity, weird and wonderful types of movements in an attempt to address things like muscle imbalances, postural deviations and stuff like that. So I think that's pretty much what a lot of people would consider all of a physiotherapist to be. And if I'm being honest, when I first started 20 years ago now, that was pretty much my naive sort of view of what physiotherapy was. I got into physiotherapy in a rather roundabout way. I came from, first of all, a military background, but then strength and conditioning. So I did my first degree in sports science.
Okay.
I was a personal trainer for a few years, but then got interested into clients that were having injuries and started to feel pain and wasn't sure about what's going on and what's the correct way to address it. And that's what led me into physiotherapy. So I went into it from a belief of trying to have a diagnostic or better diagnostic ability to find out why somebody had pain. And to say, when I went through my training, there was all these things that I was led to believe that to be a good physiotherapist, you had to do. You had to be able to spot dysfunctions using your eyeballs or your hands. You had to be able to spot gait asymmetries and pelvises that were out of place or stiff vertebral segments. And then you had to correct that and address that with your treatments and interventions to help people and get them better. And over time, slowly, gradually, steadily, with experience and also reading around research and the science of musculoskeletal injuries, you start to realize that's really not what physiotherapist or a good physiotherapist does. The way I think physio should be perceived now is it's more of a diagnostician. They are there to help you understand why you've got back pain, shoulder pain, or neck pain. But our ability to be 100% certain and specific needs to be better understood, better tolerated, better explained. This common misconception that a lot of the public has when somebody has something like back pain, that it's just as simple as a disc out of place or a muscle that's not working properly, again, is something I come across regularly, and it's very difficult and hard to try and correct that, to try and get people to understand that pain is multifactorial, it's complex, it's never as simple as just one factor in isolation contributing to things. There's often multiple reasons why people have back pain, shoulder pain. And our ability to find out the source, the root cause, again, our tests are not that specific, not that accurate. What our main role is and always should be is to ensure there is nothing serious or sinister or specific that needs much more urgent or invasive treatments. That's the first thing that we always should be screening for. But after we clear that, which fortunately musculoskeletal health has a low occurrence anyway, We then to give people guidance, advice, support, mentoring, coaching on what are the key drivers of their problems and what are the things that will probably have the biggest impact to try and help things. And it
Mm.
isn't as simple as massage, and it isn't as simple as doing a
Stretching.
something it often needs some form of long-term behavioral change, often in a lot of patients I see, some lifestyle adaptations to try and get the maximal effect of helping and of supporting their body's natural ability to get itself back to square one again.
Yeah, so many different overlapping things in my own journey as a new GP 19 years ago. The journeys you go on with patients who are depressed, who have chronic, sometimes unexplained pain or unexplained symptoms. And what you learn from the textbooks and the training suddenly falls far short of actually what the person needs. And it's a long road. I think as physio stands at the moment in the NHS, let's talk about the NHS arm of things because that will probably be most people in the general population's experience of having contact with a physio. The landscape is changing, isn't it? There is seems to be more opportunity now for physios to have contacts with patients much earlier on. I don't know whether you're in a service where you're seeing the first contact physio, the new contract that exists.
Not a first contact physiotherapist. I'm an extended scope physiotherapist
Okay.
working alongside orthopedic consultants in their clinics.
So the feedback seems to be, certainly in general practice in primary care, is very positive. And actually, from the professional side of things, having physios in primary care now able to see people firsthand is proving really beneficial. GPs saying so because they've got somewhere to move people, and GPs generally would like to be able to move more people out of their list. But my suspicion is that you can often get to patients before all this layering of complicated beliefs about their problem gets compounded by other people they meet along the journey. Now, if you're working in an extended clinic, how much does your job get complicated by things people have picked up on their route to you from consultants or chiropractors or other people that exist in that space?
Yeah, a lot. I think every other healthcare provider that somebody's a patient seen before they've come to see me is a flag that has a potential risk of causing something that I have to try to carefully, tactfully, compassionately unpick.
Yeah.
So it's something I try to ascertain when I meet somebody for the first time is what have they been told by other people? How many other people have they seen?
Mm.
What's their current beliefs around what's going on? Have they got any idea? And a lot of people have because they've been told. And often there's a lot of confusion because a lot of people get a lot of mixed messages. And that's one of the things that I find quite challenging to help people with because they start to lose trust and faith in healthcare professionals when there is such diversity in opinions and
Mm.
variations in the diagnoses and the recommendations they get for the same condition they've had. So they may go and see their GP. Their GP tells them one thing, tells them to do something. They'll then go and see an osteopath. They'll say something different. They'll go and see another therapist. They may say something different. They go on social media, hear something different, speak to a
Yeah.
friend, get a completely different view on things. Go and see a surgeon, get again another view and opinion. All these sort of mixed messages and confusion around what's going on and what to do causes a lot of people to get stressed, anxious, worried, and feel like nobody knows what's going on. Nobody knows what the
Yeah.
solution is. Therefore, I'm going to never get this problem solved. I'm never going to have it fixed. I'm always going to have to suffer with it. And I think that's a fault again of this variation in information that's out there. It's becoming increasingly harder, not only for the public, for healthcare professionals to sift through it, to find out what are the more true and accurate things that we should be informing patients about. And so I find there's another hurdle there to overcome with the education of not just the patients, but also of the healthcare professionals as well.
Yeah. Yeah. And I share your frustration in that I'm fairly interested in back pain. I wouldn't go as far as to say that it's a special interest as such, but I'm also a strength coach. And so back pain becomes part of the territory. And to meet somebody who's been told by a colleague, a certain story about a prolapsed disc and what they should and shouldn't do, if that person got that message from somebody else first, who's a healthcare professional, that sticks. And you almost have to then try and build your own credibility and position of trust to be able to even get in there
Mm.
with that. So I think getting a consistent message across healthcare professionals is, God, it's challenging in lots of different areas. And I don't think it's getting any easier as we have access to more and more information. Is there a top myth that you think is that you see, or is
Well,
there too many to
there's
list?
so many, yeah. Where to start? Probably one of the common ones is about my problems are caused by my bad posture.
Okay.
That seems to be a very common belief that a lot of people have had, or have been informed and told about, that they sit wrong, they stand wrong, they walk wrong, or they've got some muscle that's imbalanced, or something not working the way it should be, or they're just structurally shaped differently. And again, I find these informations that are given to people are often, they're quick, simple little comments that people say. Oh, it's just because you got too much lumbar lordosis, or you're in too much anterior pelvic tilt. It's quick, simple little throwaway comment made by a therapist or a doctor, but these things stick like glue to some patients. They really do.
Mm.
And then they start to get really focused on them, hyper vigilant on them. The one I see a lot about is the scapula, with shoulder pains a lot, scapular
Okay.
dyskinesis, about how this is a key reason as to why they've got impingement symptoms in their shoulder and pain. It's just nonsense, because the human body is hugely variable in its shape, in its geometry, in its anatomy, and there's so many factors that affect how somebody moves. To have any certainty to say this is a normal way of moving and this is an abnormal way of moving, it's nigh on impossible.
Yeah.
But trying to get that message across, I find really difficult and really challenging, because it is so culturally ingrained about having correct posture and everything symmetrical and in good alignment. And I know it looks pretty, and I think that's where it all comes from. Everybody wants to be aesthetically as
Mm.
pleasing as possible. But I try to inform people that's a bit of a reductionist, and it's bit of a ableist way of looking at human beings. Humans come in all shapes and sizes, all different colours and creeds, and we accept variation in how people look based on other things. So we've got to do it with posture. We've got to do it with movement as well. We've got to stop being, say, reductionist and ableist,
Yeah.
and
Yeah. Yeah.
try and explain and say that these things are very low down on the list of potential I'm not going to say they never are. Some people do movements that are probably not the most optimal. There is probably more efficient ways of doing things. Or if you've got a pain, sometimes get into habits where they carry on moving in a certain way that just sensitizes and triggers things. Saying to people, look, I think if you try to move this way instead, you're probably not going to have as much symptoms. But that doesn't mean that movement that you're doing is bad. It doesn't mean it was the reason why you've got this pain. It's just something that's contributing to it.
Yeah.
And again, it's that trying to be a bit more rational in our explanations around these things, which is where I think a lot of healthcare professionals struggle. They just like to jump on this quick, easy blame culture. It's because of this, therefore correct this, all your problems
Yeah.
will be solved.
Yeah, yeah. I think I remember being at an education event in our locality, and there was a presentation by a physiotherapy service from somewhere down south. It wasn't in the Midlands here. And they showed a video, which is available on YouTube if anybody wants to watch it. Just put in the title Load versus Capacity. I don't know if you've seen it. It's a fantastic video explaining probably the root cause of the majority of musculoskeletal pains, when your capacity is not sufficient for the load that you're putting on that particular body part. And part of the video used the example of Paralympians. And I probably saw this 10 years ago and I've never forgotten it. When I'm struggling to get across to somebody why the fact that they may have perhaps a slight curve in their spine and it's always been there, and now you're 45 and suddenly think it's the cause of all problems, it's probably not the case, because people can be incredibly well adapted for all sorts of movement. If you watch the Paralympics, and you'll see that. But I'd been practicing for probably 10 or 12 years before I had to have that made obvious to me. And many people won't see that video. So it just shows that we sometimes really need to have these things pointed out to us, even when we're working with the public every day.
Yeah, again, and I think these things are great to help people get that light bulb moment. Oh, yeah, that does make sense, and from a different perspective. And it's often these things that are driven culturally and societally around posture and position, contributing to pains and problems. But as you said, the most common reason why somebody gets a pain or a problem in a movement isn't because of the movement itself. It's normally because they've done that movement too much, too soon, too quickly. They haven't adapted to it. As you said, they've pushed their
Yeah.
tissues capacity beyond their tolerances. And it's that's a much better, much more rational explanation for 99% of all that I see.
Yeah, I think I remember some time ago you injured your back yourself, didn't you? Because you were very generous in sharing your experience of that online and what you did in response to it. Could you just talk us through that? Because it was some time ago, wasn't it? But I do remember thinking,
Yeah,
for anybody following, this is a really good way of storytelling. But you tell it.
so it's coming up to 3 years now, and it was after the COVID main lockdowns have all finished and everybody was returning back to normal life.
Mm,
And I was going back into my regular gym training, which involved doing heavy deadlifts once a week, where I tried to push up to close to 3 RM normally on
mm.
my set. And again, classic failure of getting carried away, doing too much too soon, a little bit of mistake on my part, on my programming, not really what I preach, which,
Oh,
we're
guilty of that.
we're all guilty of it
Yeah.
occasionally, aren't we? So,
Yeah.
yeah, it was an error on my part, and as I say, I just programmed things too much too soon. My body didn't take well to it, and I say I really badly herniated a disc and got myself some leg radiculopathy for a good couple of months with
Mm,
quadricep. I had femoral sort of symptoms rather than sciatic symptoms, so it was more higher up. I think I didn't get any MRIs to confirm which level it was, but my clinical signs were definitely some nerve root compression, irritation, and I caught the event as I was filming my deadlifts on my phone, so I thought this would be a good opportunity to put into, say, a vlog, a, a learning experience to show people how I would manage my own symptoms. And this is something I try to tell all healthcare professionals: is how you would manage the problems that you have, I think, is how you should also be trying to manage your patient's problems as well.
mm,
So I
mm.
thought, let's put it into practice. If a patient was to come to me with these problems and these symptoms that I've got, how would I manage it? And I documented that over a course of 3 months and just showed this slow, gradual reduction in my symptoms with its ups and downs, twists and turns, frustrating periods, doubts, worries, stresses that I had. I had all the negative thoughts running through my mind, especially when I noticed quite a lot of muscle loss in the leg,
Mm.
thinking surgical interventions might be needed, spinal decompressions, etc. So I just had this very open and honest discussion on social media, and I think a lot of people got benefit from it, but I also
Mm.
found there was a lot of negative from it as well. There's a lot
I
of
was just gonna ask that. What was the variation in opinions on what you were doing?
it was quite surprising actually, and it highlighted to me about how I think sometimes healthcare professionals like to perceive themselves as being kind and caring people, but sometimes they can come across as being rather rude and obtrusive and aggressive by offering sometimes opinions and advices that they're sometimes kept to themselves rather than going in there blindly into people's direct messages and just giving them this thoughts about what's going on. But I had various sort of comments made, particularly around, because I caught my deadlift as I was doing it, about my performance and my technique being the factor that was causing it. So there was all these discussions about my bad form, my bad ability to be able to coach other people if I can't coach myself to do
Oh, wow.
the technique. I had all that accusations, and I also had accusations about being a bad physio because I was injured, and I find that something quite interesting as well. I do find a lot of physios are a bit reluctant to tell patients that they've had similar issues and injuries themselves. And I say it's a great way to help patients understand things. A bit of shared, learned, and lived experience, one of the most powerful things I think you can pass on to your patients. And it doesn't mean you're a bad physio just because you've got musculoskeletal injuries, because you've had back pain or you ruptured an ACL or dislocated a
Mm,
shoulder, which, by the way, I've done those things as well. I think it shows that you push your body, you do what you're trying to ask people to do, you're training regularly, and shit happens sometimes. People get injured.
Mhm.
And I think we need to be a bit more confident and happy to express and share our own injuries and experiences with pains, because I'm sure you as a doctor, you get ill, don't you? You need to go and see a
Yeah.
doctor occasionally. Surgeons need surgery. Plumbers
Yep.
need to have their taps fixed from other people.
Yeah.
All trades and all professions, just because
Yeah.
they have a leaky tap doesn't mean that's a bad plumber in it because he
Yeah.
has a leaky tap in his own house. It's just what happens. Yeah,
It's just the way the world works and the
absolutely.
way human beings exist in
Yeah.
time. Funny, I'm just reading a book at the moment, The Doctor is the Patient, and it's a collection of doctors' stories about becoming a patient. And one, it's quite terrifying because I think to be facing treatment for a leukemia when you know how brutal that's going to be
Mm.
is it's brutal for anybody, but especially when you know what's involved. But the psychology of it, exactly as you say, is that I think some people exist in this bubble that I'm protected from all of that because I happen to know how it works. And then when that bubble bursts, there's one hell of a crash at the bottom of it.
Yeah, it's interesting you
Yeah.
said about that, about a little bit of knowledge can be a dangerous thing when you know what
Mm.
all the negative factors are with treatments and interventions and how that does play in your mind. Because I felt that as well with my own sort of
Mm.
experience. Although I knew statistically the chances of a disc herniation having spontaneous recovery was high and in my favor, I know it's not 100%. I know there are
Yeah.
complications and issues that can go on. And knowing that, it does play on your mind, and then you start to think worst case scenarios and start to stress and worry about that again. But that's useful to understand for a healthcare professional, because it's something, again, I don't think we do very well. We talk a lot about benefits of treatments, but when it comes to negative and harms, I don't think we're as well equipped or do a good a job in explaining that carefully and compassionately to patients.
Yeah.
And
Yeah.
again, it's another aspect of what we should be doing, is it making that's informed consent, is giving people all the information about what their options are, what the treatments are, and that
Yeah.
includes also the risks and the harms, but doing it in a way that doesn't scare the living daylights out of people, that puts it in a rational way, but allows them to really understand what are the best options for them to take.
Yeah. And I think we need to apply that to imaging sometimes as well. And if you're working in an extended scope clinic, I'm sure you're probably a bigger part of this journey. I know certainly I had a short spell of working as a private GP for an online company before they went bankrupt. People with insurance, the minute their back started hurting, felt that they needed an MRI scan. And because they were insured, often there was no barriers to necessarily getting that other than my opinion. Some people were grateful for it and other people were less interested, in my opinion, of whether or not they needed a scan. But particularly with the detail you get on an MRI scan, and I'm sure you know the data as I do, that the correlation between symptoms and imaging is not as it's not as clear cut as we would like to think. Sometimes we need to point that out to people, because you said you chose not to have any imaging with a severe back pain and some neurological symptoms. But how does that tend to play out for you as a physio? Because you would have authority to request imaging, I imagine, in your role.
I do, yeah. It's again a common difficult area to navigate well with patients. And I often say to them is that I do understand the desire to go and get a scan or an ultrasound of their painful shoulder or an MRI of their back, to get that reassurance that there isn't anything serious or sinister or needing further aggressive evasive treatments. I really do understand that desire, but as I say to people, these scans that people have are often not reassuring. They're often just the
Yeah.
exact opposite. They
Yeah.
start to cast doubts, because I can guarantee that anybody over the age of 18 is going to start to show some signs of life on scans, and that's going to
Yeah.
get reported. It's going to be put into words that you don't understand, that you're probably going to go onto Google and scare the living daylights out of yourself again. So I say the reassurance isn't going to come from an MRI. The reassurance is going to come from a good healthcare professional going through and explaining why there isn't anything serious and sinister there, and about why the scan isn't going to assist or aid in anything further. And yeah, it's a difficult conversation to navigate. And I say to people, these things, there's the circles of truth, these machines you think you go through,
Yeah.
they are not as reliable as you think. And one of the ones I often say to people, one of my favorite papers was one done, I can't remember the author now, Herzog You've got one patient with back pain to go and visit 10 different MRI centres and get the same MRI reported by 10 different radiologists. And the amount of it, there was no commonalities in seen in the reports, and the amount of variation was huge. And I use this as an example to say it's just it's individuals' interpretations of
Mm.
and it very rarely gives us any much useful information. All this subtle stuff that's probably going to be seen will be reported and say confusing and probably not assist you in any way, shape, or form.
Yeah, and it's a static picture as well, and I think that's what I try and remind people is that just like a photograph. I remember using a colleague's room once, and he'd had a calendar made of his. He'd got 4 kids, and he'd had this calendar made. And I was looking at this calendar while I was using his room, thinking, "Oh, I should have had more kids. I shouldn't have stopped at 2. Look at all those lovely photos." And when he came back, I said, "This is a great calendar. Honestly, it's made me question my life choices." He went, "What? She was miserable that day. He fell out with her that day." And I thought, yeah, the picture looks like one thing, but the story behind it is very different. And that's exactly the same thing, with imaging when it comes to our bodies. Yes, it can be really useful, but you need all this other information to go around it. How do you function day to day? What is the history behind this? And all that rich information, which is often, I think, why sometimes they just outright refuse to do some of the imaging. But when people are insured, it's a different dynamic.
Yeah, and again, it's the environments and the settings that we sometimes find ourselves working in that sort of dictates how we practice as well. Because I've tried to convince patients that they definitely don't need a scan, and I'm not going to send them for it, and they end up going above my head, seeing my managers and
Oh,
colleagues and stuff. And
yeah.
then you get reprimanded and you get challenged. And then working in healthcare, we're thinking about your reputation of being a clinician. You don't want to get patients complaining all the time. And then I do think that starts to drive how we think and how we
Yeah.
practice. And we do a lot of the time, I think you have to balance this patient satisfaction as well as trying to do the best thing, the most evidence-based thing as well at the
Yeah.
same time. And that I find is notoriously difficult and challenging for all healthcare professionals, not just musculoskeletal ones as well, I'm sure.
Yeah. And I think even when you think you're quite good at that, somebody can get you on a day or at the end of a very long day and you go, yeah, okay. On a different day, I would have given lots of compelling reasons as to why this
Yeah.
probably isn't a good idea. But you know what? And I think, again, that's just being a human in it.
Absolutely. And I say sometimes we do things, we say things just because it is a bit easier to do rather than it being technically the most correct thing to do. I think
Yeah.
there's nothing wrong with that at all. It's
Yeah.
pragmatics of healthcare.
Absolutely. It's working with people.
Yeah.
So I'd like to contrast that with the things that we see online because I work with a lot of ladies. I genuinely believe that most people will get more out of life if they're a bit stronger. And what that looks like varies for different people depending for what their entry point is. And I maintain that doing the basics is enough for a lot of people. Do the basics better is a term that I bandy around quite a lot. But I'm up against people online who want to sell fancy programs, silly bullshit, which I know is your preferred term. And in the medical world, often that comes down to things like supplements. And probably supplements are the number one thing. In the musculoskeletal space, what are you battling against most with an online narrative as being the cure, which you think, I wish I could just erase this from the system?
Yeah, again, it's probably exercise technique and how
Yeah.
training also has to be functional. That seems to be a buzzword at the moment, functional training. And it's almost a word now that so many people use and have different meanings and different interpretations. It's almost become meaningless now. I'm like, what do you mean by functional training?
Yeah.
A lot of people will see it as something that's reproducing or replicating another task or a movement, but you're doing it in a training environment to get better at doing that movement or task. And I do think there's an element of skill acquisition with certain movements that you can get with these type of exercises. But a lot of people are also claiming this is correcting dysfunctions. It's also going to make you stronger. Therefore, you're going to get better at other things as well. And I often find these exercises are done with insufficient intensities or loads normally,
Mm.
which means that it isn't going to have that same positive physiological adaptation that we want with improving muscle mass, bone density, even getting the cardiovascular metabolic systems stimulated enough to create some good physiological changes. So
Mhm.
I often say to people, these exercises, these functional training exercises, and I'm probably going to be a bit controversial, I'm also going to incorporate other sort of lower level rehab exercises in here, things like Pilates that are often bandied around as well.
I
These
was
things,
going to ask you about Pilates because the narrative I get from patients is, "Oh, I've got back pain, I need to do Pilates." And
yeah.
I often wonder, where did that come from? Where did
Again,
this
it's probably again this societal thing, physiotherapy thing, where we give low-level exercises in a belief we're correcting posture, asymmetries, imbalances, and they have to do these exercises with a lot of internal feedback about focusing on where their bodies are and which muscles are contracting. It's done at slow speeds, done at very low intensities. And as I said, these things, when you've got raging acute back pain, it just gets you moving a little bit. And again, these things do help. And I think that's where it starts to get this positive reputation that Pilates is the best thing for back pain because it isn't aggravating, because people do these things at slower speeds and lower intensities and say, perfect, when you've got raging 9 out of 10 back pain, finding something that gets you moving gently and doesn't trigger things off is great. But walking does that just as effectively as one. I think walking is the balm for acute back pain. I think just walking a little bit more has exactly the same benefits as doing some floor-based Pilates exercises. But then
Mm,
people then carry that further on down the line and say, if it's great for back pain, it must be great for other things as well. Therefore, it must be improving all these other factors in my life and making me stronger and more controlled and improving my core stability. And I'm saying, no, they won't. These
mm,
exercises are, again, just not sufficient intensity or stimulus to do anything of any significance. If you
mm,
want to get stronger, you're going to have to use larger loads, higher intensities. You're going to have to start to get the stimuluses up to get your body to respond and positively adapt. And this is a challenging conversation, particularly with ladies. There's a lot, I'm sure you find that, there's a lot of
mm,
risk for ladies wanting to do heavy strength training because of the culture again around it, often seen to be gym culture, bodybuilding culture.
mm.
And a lady say, oh, I don't want to put on muscle. I don't want to get too big and bulky. And I'm saying, I've been training for 30 odd years. I've been trying to get big and bulky and
I'm
I can't.
trying, yeah.
I can't. Yeah.
Yeah, absolutely. Yeah, that I think that myth still exists. I was having a conversation the other week with she's a friend now. She was my coach for a number of years. She's in Baltimore. And we were talking about this myth that still exists among women, to this fear of putting on muscle. And yeah, and I think I've had I wouldn't say I've had major disagreements, but I've had some kind of difficult discussions with people who feel that Pilates is enough. And it's not that I'm against Pilates, although I do take the piss sometimes in that it's just because it's lying down and it feels quite relaxing. But if that's what you do rather than nothing, then great,
Mm,
keep doing it. But it's not enough to get you systemically strong.
no.
It's not enough to start preventing falls when you hit your later years. Actually, you've got to do more specific strength training if you want those benefits in order to get that. But it certainly has become this urban myth that it is not a natural cure, but it's a companion to back pain in order to be your ticket out of it. And I have often wondered where that myth began and where it came from.
Yeah, I think it's something just physios have jumped on and started to use and adapt. And when you look at original Pilates, Joseph Pilates, who originally came up with the concept, it looks nothing like Pilates today.
Oh, really?
Yeah, so modern Pilates is, to say, very different than what Joseph Pilates originally intended it for. It's a gymnastic type of process, and he was quite, again, aggressive and intense with the movements and the exercises, and everything's now been calmed down, done much more at slower speeds, lower intensities, and then
Mm,
used to say in these rehab situations because it doesn't aggravate a lot. And say that there's a role for it, there's a place for it. It's just not going to help you when you don't have raging
mm.
back pain get strong or be getting positive physical adaptations.
One of the areas I'd love your opinion on, I get asked by patients in the NHS a lot about osteopaths and chiropractors, and I genuinely haven't got a lot to be able to say. And I just don't know. I don't really understand what they do. We used to have one in our practice who would rent the room, my room in particular. So sometimes I would see patients that she'd seen, and they always seemed to come out with this narrative that discs were out of line. And I used to say, I don't know what that means. That doesn't make sense to me. And it's not an NHS commissioned service, largely because the evidence, I think, as far as I'm aware, is still lacking. But you probably come into contact with them because I know you do a lot of teaching. And so you must cross paths with some of these. And I'd really value your opinion on where it all sits. There must be some great ones out there, like there is in every discipline, but I don't really understand what's at the core of what they do
Yeah.
in either to recommend it or steer somebody away from it, to be honest.
I get this question a lot. What's best, physio, osteo, or chiropractic? What's the best profession? And I say it's a meaningless question. So there's good, bad, and ugly in all three of these
Yeah, yeah.
professions. I know some amazing chiropractors, highly evidence based, great critical thinkers, and will be able to assess, diagnose, and treat people as well as, if not better than what I could do. And then I know some physios with reputations that are preceding them that I wouldn't trust with a barge
Okay.
pole to navigate around a diagnosis or give rational advice to anybody. And it all comes down to, I think, to philosophy at the end of the day. So that they have different teaching philosophies. Originally, chiropractic was a profession invented from the United States by one man who was a little bit of a charlatan and a bit of a snake oil salesman back in the Wild West days, came up with some idea about subluxation of the vertebrae causing interference on nerves. And when you free the interference on the nerves, the body's free to heal itself. So it's all about finding, again, this compression, irritation, interference on nerves. And this is all believed to be due to bones being out of alignment. So that's where the chiropractors come along, do all their assessments, feel the bones, see whether things are out of alignment, click, pop things using these high velocity manipulations to readdress the alignment, to reduce the interference on the nerves, and your body heals itself. But that's been truly disproven now. This subluxation process or belief is just not held up at all to scrutiny. But it is still being taught, and it is wide in the US. In the UK now, I think the chiropractors have moved a lot away from that.
Okay.
So they are now more focused again on more scientific musculoskeletal explanations and training. Osteopaths are somewhere, I think, in between the pseudoscience of chiropractic and the evidence of physiotherapy. They again have more of a holistic view around why people have pain, but it is a little bit off center in some of their views of holisticness. So they talk a lot about things like your cranial sacral fluid, your CSF, not flowing freely. And they do
Mm.
cranial sacral therapy where they feel your head and they say they can tell whether the flow is stagnated, not moving well, and all that sort of stuff. So there is this element again of pseudo scientific
Yeah.
thinking around the philosophy of why people have pains and problems and what the treatments need to be. Again, I don't want to tarnish any reputation too much because I know, as I say, it's down to the individuals. And I think a lot of people, when they get trained to do or become a certain profession, they do get indoctrinated into their way of thinking a little bit. But I do find also people then start to nowadays, because of social media, start to see the commonalities between all three and
Mm.
start to sometimes put things slightly different rather than what they've been taught in their training.
I think I've tended to take the line, and the typical scenario would be a patient comes in with a really acutely painful, usually a back, say, and they don't get sick pay. They can't wait 6 weeks for an NHS physio referral, so they're willing to spend some money, but where should I put that money in order to help me get back to work? And I've always just said, then I would pay to see a private physio because you're going to pay the same probably for that consultation as you would with the chiropractor down the road. And I can't really tell you what that chiropractor will or will not do, but I can give you a better idea of what the physio would
Yeah,
do.
I would say the same, but I'm also a bit worried about doing that with physiotherapy as well, because I
Right.
do find physios sometimes fall into that trap of desperate patients make clinicians do desperate or try desperate things or say desperate things. And I do find when people have this sort of pressure on them when someone's coming in, just that scenario that you set, they often say things, do things that perhaps are not the most evidence based or the most scientifically rational treatments. So I do know physios sometimes can fall for that trap as well, particularly in.
Yeah, as can medics, to be honest. There's various private clinics popping up around here offering things that I'm raising an eyebrow. I think it's hard for the public and it's getting harder.
And I think the hardest thing for any, I've said this many times, hardest thing for any healthcare professional is to do nothing and to
Mm,
nothing. It
yeah,
really is hard for a caring, empathetic healthcare professional seeing somebody in distress, in pain, saying, please help me, to turn
mm,
around and say, there's nothing much here that's going to do much good other than just time, just sitting it
yeah,
out and waiting it out.
yeah,
And it's incredibly challenging to do that. I know that firsthand. I try to do
yeah,
that a lot in my private practice role, online
yeah.
consultation, and the people paying you money for me to turn around and say, everything's going to be okay. Nothing needs to be done. Just give it time. Try to carry on the best you can. It will be okay. Incredibly difficult to do.
I'd say that's probably, and I say this to the new GPs when they just come off the scheme, that this will be your greatest challenge, is to learn to just watch and wait and be okay with that, because the temptation to order a random x-ray or do a sick note or just prescribe something that isn't going to work. I get it. We've been there,
Yeah,
and it is really difficult because you go into it because you want to help people
absolutely. Yeah.
and you feel like, oh, just doing something transactional, I can tick that box, and doctors love a tick box.
And I find physios get this sort of disillusionment when they come out of university in the first few years, because they are all keen as mustard and they've got all this energy about, I'm going to help people. I really want to help people. I'm going to make their lives so much better. I'm going to change the world. And
Mm,
as you say, you get into the realism of the real world. And yes, you do something with somebody, you give them a little bit of a movement, a wiggle or a rub, something feels better, and they are, yeah, that's reduced my pain 20 or 30%. Thank you very much. But it's going to be very short lasting. They come back next week, says, come back again. It feels exactly the same. And that
mm,
then starts to play in your mind, oh, perhaps I'm not as good as I could be.
yeah,
I need to learn some more skills. I need to do something else. I'm like, no, it's fine. That's just
yeah,
normal. It's what happens. Don't let
yeah.
it beat you up. Don't let it make you feel bad. It's just that these things do often only just give temporary relief, short amounts of time, smaller relief, but it is.
Yeah, yeah. Healing takes time. I use the gardening analogy quite a lot. For healing to occur, you've got to create the right conditions. Too much sun, if the garden won't grow, too much water. And healing is the same. So if you're just stressing about it,
Yeah.
you're probably not going to heal. It's not the ideal conditions for healing, but
Yeah.
how do you switch your stress off? If you've got the answer to that, then we'll both be very rich on the other side of it.
Don't just tell people, just relax. Yeah, that
Yeah,
telling stressed people to relax, last thing
yeah.
to do. Yeah.
Yeah, that's a slam door, and then not booking another follow-up appointment.
Yeah.
So just to finish off, is there anything on the horizon, newer things in physio that you're really hopeful for? I hear things that patients have paid for privately. Things I heard of somebody having a silicone injection into a frozen shoulder, or it probably wasn't actual silicone. That was eventually done on the NHS and was quite miraculous. Somebody else had some sort of stem cell injection into his knee in a private clinic, and he was raving about that.
Right. Yeah. Stem cells have been around for a while, the research on them claiming to help regenerate tissues and stuff. But everything I've seen, nothing's coming back with anything majorly different.
I did look and didn't find anything
No.
particularly
So stem
overwhelming.
cells,
Yeah.
they say, have been around, and I think they will continue to be around and pushed a bit. The one about frozen shoulder is quite interesting. There are some new novel treatments for frozen shoulder now just starting to emerge. Immune therapy injections.
Okay.
Yeah, interleukin 6s now. So we're looking into that sort of a little bit more. I love the research around frozen shoulder. I find frozen shoulder fascinating. The first thing is about the diagnosis of frozen shoulder. On paper, it's a relatively easy diagnosis to make, but in reality, it's incredibly difficult to truly spot a true pathological frozen shoulder because there's no clear, reliable tests. Just because somebody has a very painful, very stiff, restricted shoulder doesn't mean they've got a frozen shoulder, even if they're a female and 50 and got diabetes. It's just not that
Okay.
simple. So I have this whole talk around frozen shoulder when I go out teaching, is saying don't assume any frozen shoulder is a true pathological frozen shoulder, because emerging research is finding it's just not that simple.
Okay.
And a lot of people are told and given the diagnosis of frozen shoulder, and I think that starts to confuse things a bit, particularly when it comes to treatments, because I've seen some people say, oh, my frozen shoulder was fixed in 6 weeks. And I'm like, it wasn't a frozen shoulder then, because
Yeah.
true pathological frozen shoulder, we've not got any major treatments that will rectify it or cure it within 6 weeks.
Yeah.
So I think what's happening is, I say, this is confusing some of the treatment outcomes in trials, because people are being told, oh, okay, this is a
Uh,
group of people with frozen shoulder, because of, say, the criteria that we use to include and diagnose frozen shoulder isn't that reliable.
Okay.
But yeah, so hopefully, as I say, now that we're starting to learn a bit more about the pathohistology of frozen shoulder a
Mm.
bit more, there is some emerging research about using, say, some immune therapy
Mm.
to try and help manage it and treat it a bit better. Horrible
Mm.
condition, really horrible frozen shoulder, pathological frozen shoulder, probably one of the most unpleasant, long lasting, life changing conditions I see.
Mm. Mm.
Horrible condition.
Okay, you've made me think I'm probably guilty of misdiagnosing a few
Everybody,
frozen shoulders.
included. I try the best as I can, and I still get probably 50% of the time with frozen shoulder, particularly after I do an intra-articular steroid injection. Come back 6 weeks later for the follow-up and say, "Oh, my frozen shoulder's fixed and cured." I'm like, "Damn it, as much as I as much as I thought that was
Oh,
a frozen shoulder, it just
yeah,
cannot be. It just simply cannot. There was something else that was presenting as a frozen shoulder. What that is, I don't know. It
yeah,
possibly was overprotection and guarding because something else was painful, and so we
yeah,
think it's stiff, but it's not stiff.
yeah,
Stiffness is a perception that's poorly correlated with tissue status. You
yeah,
know, people feel stiff in their hamstrings and their calves after they run, but their tissue hasn't significantly adapted or shortened. It's a sensation that we feel. And I
yeah.
think we make that mistake when we assess people and say, "Oh, that's stiff," and it feels stiff to us and it feels stiff to them, that we think some structure has shortened or adapted. But
Mm.
it isn't always that simple. Something else
Mm.
drives these sensations of stiffness.
Yeah, yeah. Tight hamstrings. I hear that bandied around by people all the
All
time.
the
They saw
time.
somebody
Yeah,
say they have
yeah,
tight
all the
hamstrings, and I
time.
think,
And there's some
I know.
interesting study that when you anesthetize people or you alter their perceptions about how their stiffness and their restrictions and range of movement completely changes. Hugely
Really?
changes, yeah. Virtual reality hugely affects ranges of movement and stiffness. And it's amazing how you preoccupy the brain or you change the
Yeah.
perception of something and how all of a sudden this tight hamstring, restricted straight leg raise vanishes, disappears instantly.
I'm just imagining bringing that into clinic. Oh, you could have some laugh at that. Flipping it. Get these glasses on, Granny. Let's have a little look what you can really do. That would be class. That's brilliant. Adam, any final messages that you want to wrap up on for a take-home message for people?
Yeah, I think that one thing I tell people, if you've got any musculoskeletal problems, back pain or anything, my biggest advice is be patient and give it time because it really is the best cure. And that's why
Yeah,
there is this saying, time heals
yeah,
all things, because it really does. Not many things in musculoskeletal medicine outperform time alone. And to say you are the best person to get yourself back to square one. Don't put
yeah,
your faith or reliance too much into any healthcare professional to fix or cure you. There are many out there that can help, support, guide you, motivate you through the bad periods. But at the end of the day, you are the person that will get yourself back to square
yeah.
one.
Yeah. And the person best placed to recognize the patterns, I say to people all the time, the majority of my job as a doctor is pattern recognition.
Mm,
And there will be a pattern to your pain, even if you haven't identified it yet. But sometimes you've got to zoom out, right out, sometimes over months or across the year, and identify those patterns. And when you recognize that, we can start to then isolate the trigger factors. And that can help enormously. But
absolutely.
sometimes people don't zoom out far enough, I think,
They
to
do,
perhaps
and
look at the
they
whole
don't.
cycle of the year.
Exactly right. They don't look at the other things that could be contributing to their symptoms. It's always about the movements and the mechanical factor. They're not looking at their sleep, their diet, their stress levels, and stuff like that. And it's making them aware that these things can also have huge impacts on their symptoms. And you say zooming out, noticing that
Mm.
when I get really stressed or I only get 4 hours sleep, my back pain is 30 times worse than it, regardless of whether I was doing the gardening or not. So it's the mechanical factors, maybe it, but there's these other things as well.
Yeah, great. For anybody who's not following Adam online, your handle on Instagram is the sports physio, isn't it? At
It
the
is,
sports
or it's all
physio.
my name, Adam Meekins. I
Yeah,
do go under my brand name, the pseudonym of the sports physio as
yeah,
well. Yeah,
yeah. And I think so much evidence-based, no nonsense content is on your platform. So I recommend people follow you if they're not already. But thank you, Adam.
thanks,
Great
Lynette. Yeah,
conversation.
good chat.
Really
Thank you very
appreciate it.
much.
Thank you.